arteries, and we have veins, and we have capillaries. So arteries are always carrying the blood away from the heart. And arteries are going to be under pressure, so we're going to feel them pulsing. And arteries are going to vasoconstrict and dilate because they have a thicker muscular wall. And they go from arteries big at the aorta, highest pressure, and then they get smaller as we go away. We go to arteries, to arterioles, and then finally to capillaries. So the pressure is dropping the further we get away from the heart, and the smaller the vessels get. And then at the capillaries, we switch over, and we start in with the veins. And veins are going from the smallest to larger, and they end up at the superior vena cava. And that's where the pressure is lowest. So veins are kind of the opposite. We go from small veins to large veins. They carry oxygen-poor blood. Arteries are oxygen-rich. And veins have thin muscle walls, so they're steady and unchanging. We don't feel pulsing in veins. We feel that in arteries. So they're steady and unchanging. Because they can't vasoconstrict and dilate, they're dependent on other things to get blood up to the heart. So we're dependent on the thoracic cavity of inspiration and expiration. We're dependent on skeletal muscle moving around, and it contracts where the veins go through. And then we also have valves that help push the blood up. Once it goes up, the valve is shut, and then it doesn't come back down. And that's what varicose veins are all about, is the blood pulls back down. Those valves get a little leaky, and the blood pulls, and the veins can get distended, and that's a varicose vein. And they can get tortuous, they can get very big and bumpy, or they can just be spider veins. So that's the overview of arteries and veins. Remember, arteries have the large lumens, they have a thick muscular wall. Page 696, the capillaries are going to be the smallest vessels. This is where gas exchange is going to occur. And then we look at our three different types of capillaries on page 697. The most closed capillaries are called the continuous. All of our capillaries are going to be permeable, but to what extent? So continuous capillaries are the least permeable, and this would be like our barrier of our skin. We want to have a closed barrier, but we can still sweat, so there's a little bit of movement across there. In the middle, we have the fenestrated. So we have increased permeability. This would be like the kidneys in the intestines. We're flowing things through the kidneys, or absorbing in the intestines. And then the most open would be the last one, the sinusoidals. Those are very open, and where we need a lot of filtration, like in the liver, in the spleen. I think your book says bone marrow as well. That's capillaries. And then we switch over to veins. And veins are going to be collapsible because they don't have that thick muscular wall like arteries do. They still have a thin muscle wall, but it's not sturdy. So they kind of close down on themselves like a boomerang. And veins are blood reservoirs. Blood hangs out there, but it's just kind of sitting in there. So it collapses down in on itself. Veins have valves. And then when those valves aren't working, that leads to varicose veins on page 691. And then we saw this in lab where where vessels come together, blood vessels, arteries or veins, they come together. And we have branching, and they branch out. This is the circle of Willis where we branched out and we looped up and around. That's called an anastomosis. And we branch around joints. We branch where we need a lot of blood flow. So in our arteries, we're branching around our joints, our heart. We saw all the different branches that were coming off in the cardiac vessels because we want to make sure we have lots of routes to the heart. Same thing in the brain. We're going to have lots of offshoots so that we can get lots of blood supply. So anastomosis of the arteries. And And then we got into flow. So same old equation. Our flow equals pressure and resistance. So flow equals pressure over resistance. And that's our direct relationship. The greater the pressure, the greater the flow. So increased pressure equals increased flow. And then the inverse relationship, increased resistance. Whatever that be due to. A blood clot is in there, plaquing is in the vessel walls, vasoconstriction. Whatever that restriction is going to be in the blood vessel, when it's a smaller opening, then that's going to decrease flow. So that's the inverse. So when we're talking about the vessels, we're going to talk about what is the blood pressure. So the more the blood pressure, if our blood pressure is high, that's going to go up and cause problems. And we're going to have a lot of resistance for driving that blood pressure up because we're vasoconstricted. We know blood is 5 times thicker than water, so it has a viscosity, so that's going to add to resistance. How far we have to go can increase our resistance. So the larger we are, sometimes we hear about really large people having trouble with circulation because it has to go further, so there's more resistance. So we see this in our really tall people. When you're getting into 6'5" and above, 7-foot tall people, they have circulatory issues. Certainly diameter, a big factor in resistance. Open, vasodilation, little resistance, vasoconstriction, lots of resistance. So that's our whole relationship with that. Questions over that equation? It's the same thing when we get into the respiratory chapter, but instead of blood, we're talking about the flow of air. So if we have a lot of pressure, we're going to have good flow. Where we get talking about resistance in the airway is asthma, bronchial spasms, vasoconstriction sort of things. And when we get resistance in the lungs, then we have decreased flow, so we have more time breathing. So this equation is true in anything, whether we're talking about, it's all about fluid dynamics or air dynamics, whatever it might be. It's always that same equation. It just depends on what's flowing through the channel. Okay, blood pressure, we're going to measure in the brachial artery. The top number, maximum pressure, is systole, that's around 120. And then diastole, after contraction, so that's lower, that's 80. So we should be somewhere in the 120 range for normal blood pressure. 110 is normal for a lot of people. If that's their normal, that's fine. Some people even go down to 100, which is getting pretty low, but if you're a small, thin person, you'll see that kind of blood pressure on people. So we want to watch that top number when it goes between, know your values for hypertension, from 120 to 140, that's mild. Above 140, that's moderate, and above 160 is severe hypertension. Got a PowerPoint on that. And then the bottom number, the diastole, that should be 80, and there's not much pressure in there because this is after contraction, so there shouldn't be a lot of pressure going on in that number. So once it gets above 90, you automatically are considered hypertension because it shouldn't have that much pressure. And then capillary pressures goes from about 35 to 17, so 120 over 80 blood pressure, that's a lot of pressure, and then we just keep declining as we go to those capillary beds. So it's low in capillaries, 35 to 17 millimeters of mercury. And then we keep on declining in veins, and it goes lower and lower. By the time we get back up to the vena cava, we're almost at zero, or we are at zero. So veins are the lowest, capillaries are in the middle, arteries are going to be the pulsing ones where we're feeling the most pressure. And this is how we maintain blood pressure, is we have to have flow, we have resistance, we're going to control it through that. If our blood pressure gets too low, we need to increase resistance, so we're going to vasoconstrict to push the pressure back up so we can get the blood flowing. So it's always about that equation. How are we monitoring blood pressure? Is flow, pressure, and resistance is what we're always looking at. And how we're doing that in the vessel chapter, we're vasoconstricting and we're vasodilating. If we vasodilate, we open everything up with little resistance, and so we're going to have good flow, low resistance, high flow. Low resistance, high flow, indirect. Or if we're vasoconstricted, we have a lot of resistance, so we're going to go the opposite direction. Always about this equation here. All right. Short term, how do we regulate what we were just talking about, vasoconstriction and dilation? And who's monitoring that? The carotid arteries in our neck and the aorta. We have receptors there, they're called baroreceptors on page 705. They're monitoring blood pressure, and they're either going to vasoconstrict or dilate, help keep that in homeostasis. We also have chemoreceptors. The baroreceptors are going to be in the vessels monitoring stretch, and then the chemoreceptors are in our carotids and our aorta, and they're monitoring what's the O2 level. So if our blood flows down, we know our O2 level is going to be down. So we're monitoring it with stretch, baroreceptors, and chemoreceptors are monitoring what is the chemistry, what's the O2, what's the CO2, what's the pH. We're going to monitor all of that with the chemoreceptors of what's going on with the blood. And then we talked a lot about the whole chemistry, the short-term regulation, vasodilation and constriction. And then we got into the chemistry. We secrete renin, we secrete angiotensin 1, which goes to 2, which talks to ADH. So we're going through that whole hormonal, whole regulation thing there. So that's our short term, is the chemistry of it. And we're going to, so that's the main idea you need to know about that. It's just the short term is the renin, angiotensin, ADH. And what we're going to do is we're trying to get to ADH and aldosterone, and we're trying to say hold on to fluids if pressure is low, or release fluids if pressure is high. So we're going to move fluid based on that chemistry. And that's the whole idea. Questions on that one? So you don't have to know the details behind each chemistry, behind each hormone or chemistry. Just know that they all go together for short-term regulation. And then long-term, we're going to use the kidneys because it takes a while to process. So we're going to go through that whole process. Directly, we're going to say, again, what are we doing with urine? Are we holding on to it or are we pushing it out? Hold on to it to get volumes up, pee it off to get volumes down. So do we want more volume? Stop peeing. ADH is going to come on board and say hold fluids. Or if pressure is too high, it's going to say push off fluids. The ADH won't come around, and we'll just pee off the fluids. And then volumes go down and pressure goes down. That's our direct. And then the indirect method, what we're talking about is the whole hormonal thing. We have to go through all the chemistry. So the kidneys play a big part in the vessel chapter. Hypertension, know your values on that. We'll talk about that. The opposite, hypotension, when your blood pressure is too low, and then you're going to get dizzy and pass out because there's not enough oxygen flowing up to your brain because your pressure is not high enough. On page 712, we looked at when we're exercising, how we divert blood. Normally it's evenly distributed, or not evenly, but it's distributed. And then when we get active, we're going to shunt it from other areas like the digestive system and send it out to the skeletal muscle. So it's still all supply and demand coming into effect here. We're going to take it from other areas and give it to skeletal muscle when we're exercising. So we have lots of flow to feed those muscles. That is it. That's where we stop in this chapter. It talks about the lungs and skeletal muscle and the skin and the brain. We've been talking about that all along, so nothing specific over that. And then that's where we stop for this chapter. And the rest of the chapter is what we've done in lab. So stocking on page 712. And then we've already tested over arteries. And then veins is what we did in lab. And remember, veins are pretty much the same as arteries, except we changed over to our carotid arteries, and then we have our jugular veins. So they both are going up to the head, but instead for veins, we'll call them jugular, internal, or external. And then we learned basilic out here goes in the axillary, and cephalic goes on the outside. So those were basilic and cephalic, and then we have jugulars. And the hemiazygous vein was the other new one that goes down the vertical, up and down the chest cavity. Posterior intercostals goes across, and hemiazygous goes perpendicular. And those were the only, and the saphenous on the leg. So femoral and then saphenous. So reviewing our lab for today, right? Lab review. Other than that, everything else follows along with the arteries, and then we're just going in the different directions. So when the questions say, where did it just come from, or where is it going to for the lab test next time, remember to switch directions, going up towards the heart. So if it's like in the common iliacs, it'll say, where did it just come from? The femoral is feeding up, and then we have external iliacs, common iliacs, and going up. So remember to go up when we're talking about veins. And then the other thing we talked about with vein was on the back of the mesentery, where we were talking about how the splenic comes in and the superior mesentery come in, they feed into the hepatic vein. Remember on the back of the mesentery, we showed where those three were coming in. And then you can see that vein on the liver. And then the other funny thing about veins is if we're looking at the back of the heart or in the lungs, and then that's where the veins are going to be red. So the veins on the pulmonary veins are red on the back of the heart, and inside the lungs, the pulmonary veins are red on the lung. So that's the only thing that would be different when we take the lab test next time over veins. So I'll refresh your memory on that next week. All right, but then that specific step on the lecture test, stopping on page whatever, 712. Okay. Any vessel questions? Guys, we're looking thrilled to be here today.